Welcome to today's session entitled Blueprint for Complex Care, Opportunities for Philanthropy in Healthcare and Social Services. Before we get started, I would like to go over a few items so you know how to participate in today's event. When you joined today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time, and we will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. Go ahead, John.
Thank you, Clara. I'm delighted that so many of you have joined us today. And I want to have a special thanks and welcome for our friends at Grantmakers in Health who are co-sponsoring this event today with us. We also want to thank the Six Foundation Collaborative, and that includes the Commonwealth Fund, the John A. Hartford Foundation, Peterson Center for Healthcare, the Robert Wood Johnson Foundation, the SCAN Foundation, and Millbank Memorial Fund for their support of this work. This collaborative seeks to help healthcare organizations participating in value-based payment models, including accountable care organizations and Medicare Advantage plans, to adopt evidence-based interventions to improve outcomes and lower overall costs for the care of people with complex needs. The recently released Blueprint for Complex Care is providing clear, actionable steps for further developing a wide range of efforts aimed at improving the lives of people with complex health and social needs and advancing the field of complex care. We are so pleased today to be joined by three outstanding speakers. Mark Humowicki is the Senior Director at the National Center for Complex Health and Social Needs. Susan Mende is the Senior Program Officer at the Robert Wood Johnson Foundation. And Kelly Pfeiffer is the Director of High Value Care at California Health Care Foundation. All of our speakers today will be sharing more about the Blueprint and discuss how this tool can provide a framework for funding in complex care. So welcome to you all. Before we get on our presentations, I want to remind you once again that you can enter your questions at any time in the question box that you see on the right hand of your screen. So Mark, let's start with you. Please share with us some of the goals of the Blueprint and opportunities for philanthropy to be involved.
Great. Thank you so much, John. It's a pleasure to be with everyone this afternoon. Next slide, please. So I am the Senior Director for the National Center, which is housed at the Camden Coalition of Healthcare Providers in Camden, New Jersey. Which was the National Center was launched about 3 years ago with support from Robert Wood Johnson Foundation, Atlantic Philanthropies, and AARP to help catalyze this new emerging field of complex care. Our role is to connect and convene people in the community of complex care, to inspire change by sharing success stories from around the community, and to provide support to folks in the field through training, technical assistance, and resources. We put on an annual conference each year called Putting Care at the Center, and this year's conference will be in Memphis in November. Next slide, please. The Blueprint really serves as a strategy, not just for the National Center, but for the field of complex care. When we started the National Center 3 years ago, there was a lot of exciting activity going on, pilots and programs that had been run for a number of years, success being shown in various evaluations, and the start of sort of new frameworks. But there really was sort of a lack of coordination, a lack of commonly accepted terms, and what we decided was we really needed to bring the field together to start to set a path forward. And so the Blueprint really serves that function. It is a collaboration of multiple organizations, the Camden Coalition's National Center, the Center for Healthcare Strategies, and the Institute for Healthcare Improvement, IHI. It was funded by 3 funders, the Commonwealth Fund, Robert Wood Johnson, and SCAN Foundations, as part of the 6-funder collaborative. And it is really trying to do 2 main things. One is to assess the current state of the field of complex care. And the second is then to set a course for where the field needs to go in order for it to be strengthened and for evidence-based programs that improve the well-being of people with the most complex combinations of medical, behavioral health, and social needs, for that to become standard of practice, something available in any community and not just in the most innovative, the most cutting-edge organizations in the country. So we hope that the blueprint will serve as a framework for the field moving forward, and we'll get into a little bit more later about how we're activating and hoping to live out the blueprint. So the next slide really gets at complex care. I understand this is a term that not everyone necessarily understands, and so one of our goals was to really try to put some language around what we mean by complex care so that people could start to have common frameworks. So there are a couple of key concepts in this definition. One is that the population is characterized by extreme healthcare utilization and cost. A second is that the root cause of that utilization and cost goes beyond pure medical disease and includes some combination of mental health and addiction, and social needs. And the third is that it's the lack of coordination and the silos that exist between our health care systems and our social care systems that really contribute to the inefficient use of resources and fails this group of vulnerable populations. On the right in this slide is a picture of what we're calling a complex care ecosystem. So programs that are undertaking complex care often serve to coordinate the services for individuals. And while that's important, we know that to truly improve care for folks, we need to go beyond the level of an individual coordinator and to build systemic connections across not only the healthcare system, but across the healthcare social sectors, including housing, food, transportation, criminal justice, etc. And so this complex care ecosystem can and should exist in any local community, but really needs to be knit together through new structures, leadership, and financing that allows for folks to come to the same table and collaborate on an ongoing basis. Next slide. As part of our defining the field, we also identified 5 core principles of complex care. The first is that it's person-centered, meaning it's focused around the individual's needs and preferences. It addresses the whole person as opposed to just the sliver of maybe medical needs, and it's provided in a trauma-informed way. The second is that it's equitable. It tries to advance health equity. It recognizes that many individuals face needs as a result of systemic inequalities like poverty and structural racism, and that the field values the experience and wisdom of people with lived experience. It's team-based, meaning that in order to really accomplish the work of advancing the health of people with complex needs, we're going to need multiple professions. It's also cross-sector. It's got to span those sectoral sort of divisions. And it's data-driven. Data is used not only to identify the most complex patients, but also to ensure continuous improvement and to be able to share information between the various members of that ecosystem. Next slide. So the blueprint was developed over about a 15-month period. Starting in the fall of 2017, we launched the project at our national conference in Los Angeles. we welcomed participants in that conference to start sharing what they thought of their local complex care community, who were the key stakeholders, what were the core principles. And throughout the process, we really sought to be as inclusive and reflective of the community's values as we could be. As we moved into the winter of 2017, we conducted the research phase, in which there was an environmental scan looking at literature, published in gray, interviewing of experts, and again, a very diverse range of experts from all different walks of life, all different types of programs. By the spring, we pulled together our initial findings and tested that with an expert convening of more than 20 folks, many of the early thought leaders within the field, and they helped us to refine not only what we were finding about the current state, but also what we were prioritizing as recommendations. We didn't want it to just reflect the views of those experts, so then we took it out and conducted a series of surveys and tested those with more than 400 stakeholders through that process, and then turned to the drafting process, which we finally finished the blueprint in November and launched it at our conference in December of 2018. And really there should be a fifth phase, which is the dissemination and activation, which is happening in 2019, and today is a part of that. We're really trying to reach out to stakeholders who are part of the community but weren't aware of the blueprint, engage them, and really make sure that we're all working from the same sort of playbook. Next slide. This just captures a little bit of how many people were consulted as part of the development process. So 140 participants at our conference that participated in some way, 108 different publications that were reviewed and included, 45 practitioners who were either part of the interviews or the expert convening, over almost 400 surveys that were completed. And the last number, 6, is the leaders of other fields, because we knew that the process of building and strengthening a field was not unique to complex care, that other fields like palliative care and hospital medicine and supportive housing had all done similar types of things and had different experiences. So we did a series of interviews with those field builders to understand their experience and their lessons learned. Next slide, please. So when we started, we had this metaphor of a blueprint and a house, and we knew there were lots of different rooms to a field, but we were at risk of sort of ruining that metaphor at some point. And so we were lucky to come across this strong field framework, which is a framework developed by the Bridgespan group and based on work of over several dozen social impact fields, studying those to understand what the components of a field are and how they went about becoming more influential and more broadly accepted in their work. And so this was really helpful to us. I'll quickly run through the components. The shared identity is sort of how the community, the field itself defines itself. Standards of practice is how we go about implementing the work in day to day. It's the models, it's the training for the workforce, it's resources to support good practice. Knowledge base is really the research and continuous improvement mechanisms. Leadership and grassroots support gets at the influence of the field, their ability to change the broader systems that we're part of. And then funding and supporting policy is really critical to making sure that whatever models and practices are sustainable from day to day. Next slide, please. So quickly, I'll just run through our overall assessment of the field by domain. And it's important to note that we found very few pure strengths or pure weaknesses. Instead, what was often the case was that a strength, still had some components that needed to be improved upon, and a weakness was maybe in moving towards becoming a strength. But on the shared identity, there was a lot of agreement about what the problems we're trying to solve, what the goals are, but there was a lack of shared language. and confusion about the target population. Those were things we're trying to address through the blueprint. On the standards of practice, there are good models and promising practices that are being identified and even frameworks introduced for that. But the data sharing to actually build that in practice is limited, and the workforce isn't necessarily prepared to deliver good quality complex care, so there's work to be done there. On the knowledge base, again, growing evidence base, good work being done on segmentation of the population, a community of researchers was starting to emerge, but there's a lot of work that needs to be done to make sure we have metrics that accurately describe the value of complex care. In terms of leadership, again, it's a high priority for a lot of stakeholders, but we need to make sure that we're incorporating the voice of people with lived experience as best we can, and that we're helping folks develop really high quality cross-discipline, cross-sector partnerships. And on the funding side, while the shift towards value-based payment certainly helps accelerate the interest in complex care, we know that we're in transition and that folks need help really making that work to support programs, and that the social and behavioral health sectors are very different in terms of how they're funded. Next slide. So here's our set of recommendations, and I don't have time to go through all of them, but I encourage you to take a look at them. And the next slide describes them across the domains of the Strong Field framework. And so you can see that some of those recommendations really speak to a single domain, whereas others across multiple domains. And again, I don't have time to go through these, but Susan's going to talk about a few of them where we're starting to think about concrete work that can be done to advance these recommendations. Suffice it to say that these are broad. There are many sub-recommendations within these, but it's about building sort of some of the core building blocks that the field needs to be able to advance itself and strengthen the work so that we can be sharing best practices and teaching in a more consistent way. Next slide. Finally, our next steps to catalyze collective action are to start to prioritize recommendations, to establish mechanisms for coordinated action, really among folks that are strengthening this field, and to engage stakeholders nationally. And thanks to grantmakers in health and grantmakers in aging today for this opportunity to share it with all of you. And we look forward to other opportunities to share this work, and look forward to the questions and conversation that's coming after this. I think that's the last slide. Oh, no, last slide is that as part of our engagement, we've given folks the opportunity to come in as complex care champions, which means that they're endorsing the findings of the blueprint and they're committing to help share the resources and the message of the blueprint. And you can see over 60 organizations that have signed on thus far to become complex care champions. If you're interested, there's an opportunity to do so following this program. Next slide. You can also sign up here for more resources to continue to learn about complex care. And next slide. And so without further ado, I'm going to turn this over to Susan Mendy from the Robert Wood Johnson Foundation, who is one of our great champions of the field of complex care. Susan?
Thanks, Mark. Good morning, good afternoon, depending on where you are, and thank you, everybody, for tuning in today, and certainly to the hosts. So as Mark alluded to, the Robert Wood Johnson Foundation is really proud to be a founding sponsor of the National Center for Complex Health and Social Needs, and also a funder of the Blueprint for Complex Care that about which Mark has just been talking to you. Many of you will know we at RWJF are really committed to working alongside others to build a national culture of health, and that, simply put, is a place where the United States in which everyone has the opportunity to live a healthier life, no matter who they are, where they live, where they come from. And the foundation was an early supporter of identifying approaches to better treatment of people who have complex health and social needs, many of which are extremely challenging. It's been really a privilege to be able to support this work and watch it blossom into not just an approach to care, but really growing into a field of people who are expert in providing it. And we're very excited, along with all of you, to watch it grow. Next slide, please. So we're currently at Robert Wood Johnson Foundation focusing on fostering stronger engagement amongst healthcare, public health, and social service systems, and very importantly, bringing the voices of community members into change. We think of successful models for delivering care to people with complex health and social needs as sort of a poster child by what we mean by aligning all these systems. In our work, alignment aims to identify and to address the root causes of poor health that don't adhere to the boundaries that we often place on sectors, fields, and professions. We all know that being healthy does not depend on a good health system. It depends on many different types of systems, and all of them being aligned. There are so many stakeholders in this field and playing a part in providing complex care. So we often run the risk of duplicating or even siloing efforts, which poses difficulty and certainly slows progress. And the blueprint really comes at the right time to address this conundrum. Complex care has grown from a radical new idea into a movement and now into a field of its own. So our work with the National Center, with the Institute of Healthcare Improvement, and the Center for Healthcare Strategies is continuing beyond the work of the blueprint and even growing towards a point of more collaboration amongst all the stakeholders in this field. At the Foundation, we are trying to do our part to achieve greater alignment in the field of complex care by building on the 6-funder collaborative on complex care to which John alluded in the beginning of the webinar. The 6-funder collaborative has invested in the blueprint for complex care, and we're now really excited to support the National Center to collaborate with others. With a bit of a focus, we're going to talk about some of these 11 blueprints ambitious recommendations that we are discussing with the center. Next slide, please. So first, one of the things that the blueprint identified was a need for a field coordinating committee, and this field coordinating committee would play a few key roles. It would establish and convene expert working groups to build consensus on approaches in some key areas of complex care. It would work to promote consistency, coordination, and collaboration on these strategies, very much a theme throughout the blueprint. So basically, the aim of this committee is to help the field stay on track as we define our priorities moving forward, and playing a key role in collecting and disseminating information and really sharing all along as different initiatives progress. The current thinking is that the National Center would convene this committee and would bring together many other individuals and organizations to provide leadership, do things like chair and oversee working groups. This was highlighted in recommendation 10 in the blueprint. Next slide, please. Another area that we're looking at is developing an agreed upon set of core competencies to build effective educational programs for current and future workforces in complex care. We know that the workforce in this field is absolutely bedrock to making any kind of progress at all. This is referred to in recommendation 1 in the blueprint. So one approach to this is that the field coordinating committee that I just discussed would create an expert core competencies working group that would include representation from an array of complex care models, settings, and diverse professions, and very importantly, include consumers and caregivers. So the goal with this core competencies is to really build on what's already developed in a range of core competencies, in a range of initiatives, and not to create hundreds of new competencies, but get consensus on what the core competencies for a complex care workforce really are. And these would be broadly applicable across populations and settings. Next slide, please. Another recommendation that we're looking into is recommendation 7, which is strengthening local cross-sector partnerships by building a complex care ecosystem. This involves really looking at the root causes of complexity and not just addressing the symptoms like homelessness and chronic conditions, And this work would build on the National Centers of Experience in providing technical assistance to collaboratives and health systems across the country. The idea is to codify this ecosystem approach and to create a compendium of tools and resources that would, again, be widely shared. I think you're going to hear widely shared as an ongoing theme in all of this work. Next slide, please. We're also looking at curating, developing, and disseminating resources that would foster peer-to-peer connections. This is a bit of recommendation 1 and a little bit of recommendation 11. We know that many health and social service systems across the country have created their own complex care programs, but in practice, many times they have to recreate the wheel, start from scratch, and there's a lot already out there that can be built upon. So the idea would be to develop this compendium of best practice resources and, again, to share widely. And this would be done through getting a collaborative of some organizations who are really leading the work in this field and developing along with them this compendium of resources. It would touch things like workforce recruitment, process improvements, data integration, and much more. Next slide, please. And the National Center has a very robust consumer scholar program. And this program really demonstrates their commitment to valuing the leadership of people with lived experience. This is discussed in the 6th recommendation of the blueprint. National Center's Consumer Scholar Program is part of its governance, and it really supports these scholars to work with their local institutions to embed the consumer voice across all of the work that they do. So this recommendation and this work would really build on these scholar activities year-long, including webinars, and it would be developing resources such as approaches to embedding people with complex needs into system change, really building, helping to build the knowledge and the infrastructure for getting consumer voice throughout everything that we do. So tackling each of these 5 areas is clearly a challenge, but I think that these efforts represent a big step in bringing the blueprint's recommendations to life, and fostering alignment and coordination amongst funders, I think, also reflects the original intentions of the blueprint. Next slide, please. We know that as the field progresses, we need to expand the evidence base for complex care, and as Mark discussed, focus on building a strong business case for why it needs to be covered, and such things as insurance networks and payment models, again, working towards paying for value over volume. And certainly we know that many health systems and many systems and payers need demonstrated cost savings. And so there needs to be more work done in this area. And we really need to work towards this idea that complex care approaches are seamlessly integrated into the healthcare system as a rule rather than the exception, so that no matter where people with complex needs go, they can find care that's designed around their priorities and range of needs. And the blueprint is a key step in this work. Next slide, please. And that's why we at Robert Wood Johnson Foundation are placing such a priority on this work. We believe that by working with others, we can make a difference with our grant making, and that by helping to support implementation of the blueprint and increasing the alignment of our systems, we can make headway in our larger goal of building a culture of health. This is going to take time, but with the blueprint, we have a path forward, and we're always looking for more partners. So thrilled to be with all of you today discussing this, and we hope to hear from you as we continue this work. And I am now going to hand over to Kelly Pfeiffer.
Well, thank you. I really am honored to be on this call. I work at the California Healthcare Foundation. Some of you may know us as a state philanthropy that's devoted to trying to fix healthcare systems in California with a particular focus on underserved and the Medi-Cal program. There's a little coffee shop in my neighborhood that has a great sign that's almost become my motto of give me coffee to change the things I can change and wine to accept the things I can't. And the national landscape and the federal administration has always been a wine problem for me. And I'm very grateful for the partners on the call today for really tackling that national landscape and creating order out of what has honestly felt like a bit of chaos, because we've been working in the area of complex care for years, but it did always feel like people were defining it differently, approaching it differently. So next slide. And the way that we at CHCF are thinking about this problem is how to pull multiple levers all at once to try to achieve better outcomes. Because we know the goal is quite clear. People with mental illness die 2 decades younger than everyone else. People with addiction die a decade younger than everyone else. But to fix that is going to take a lot of hard work and patience and pulling all of these at once. We have to figure out how to use technology where it can help, how to leverage consumer advocacy, how to use data and transparency to make sure that we're actually delivering outcomes that matter, how to change payment and policies that drives the right behavior. You know, reflecting on a friend of mine who's in a commercial plan who said, oh yeah, we did an intervention on complex care, but it didn't prove to have an ROI in a year, so we gave up. And knowing that policy and payment need to drive the kind of outcomes we need to see, and it takes time, because these types of interventions are not going to show ROI in 12 months, and they may not even show the kind of quality outcomes we need in 12 months. It takes a lot of time and effort to turn these systems around so they really benefit the people that need to be served better. And then importantly, like, what are the clinical models at work? And we've done some pilots, and in the next couple of slides I'll go through some examples of ways that we've tried to work on improving care for people with complex needs. Next slide. In the area of data, many of you may know we have a waiver program in California called Whole Person Care, which is trying to identify in each county the folks that are using multiple services and not being served well. And how do you get all of these sectors to work together effectively? And a big problem, of course, that's front and center is how do you share data so that there's a common care plan, and that respecting consumers' rights to privacy and federal privacy laws, how do you still make sure that people are all trying to work on the same goal and that the care is not so chaotic? We also have done work in the past on some of the hard work of how do you actually identify the right people who will benefit by an intervention, and then how do you engage them well? So we've done some issue briefs on the topic of data and clinical data sharing. Next. We have a arm called our Innovation Fund, which does program-related investments. So we identify for-profit companies in a field that we think can change care and improve care in the safety net, and then we do loans to them that get paid back. So we're not ultimately trying to make money, but we're trying to improve care. And so one example is Eddie with the Collective Medical, and this is a tool that enables emergency departments, health plans, and primary care providers, they're currently working on the social sector as well, to get real-time alerts and then meaningful instant data sharing using algorithms, so that when an ER doc is seeing a patient in 90 seconds, they get a care plan, they get the key clinical information they need. And so someone goes from being a blank slate to someone who's been to 100 ERs and has, and that appropriate care can be delivered. We did another investment in Quartet, which is a technology platform that enables better integrated mental health care with physical health care. Next. We collaborated with the National Center to do a project where we tried to create complex care teams in federally qualified health centers and county health centers. Really, really hard work. And what we kept encountering over and over is that the work was not reimbursed, and it's really difficult for safety net delivery systems to do work that they're not getting paid for, even when they began to see, patients loved it. The people working on the team loved it. They were really making progress, but some of the projects actually ground to a halt because of staffing issues and other issues related to trying to make sure payment is aligned with the kind of care we're delivering. We're currently working with the Transitions Clinic Network, and we're really excited about this. This is a national program that helps community clinics embed health workers who have lived experience, who've been incarcerated, and actually help empower them to be an equal on the team with the doctor, the nurse practitioner, and the social worker, and serve as a cultural broker for people who have just been released from incarceration. And they've got great outcomes. They've got a good model that's very much aligned with the blueprint, and we're trying to work with health plans to see how this type of model could be sustained. Next slide. But what we keep coming across in California is, even though we're trying to work all of these levers, one of them, next slide, payment, is just dwarfing everything else. It's almost impossible to make progress on a clinical model and have it stick and stay after the grant is over unless we solve our payment problem. Next slide. Because California, unfortunately, is one of 6 Medicaid carve-out states. So those of you who are fortunate enough to live in a state where this doesn't exist would need to appreciate how hard it is to integrate care. If you have 3 different ways that care is paid for in Medicaid, it's called Medi-Cal in California, 3 different delivery systems, 3 different training programs, 3 different auditors coming in to try and make sure that their billing line is correct. So even when we've attempted in systems to have SUD and mental health and medical care delivered in a seamless way, it really runs into the carve-out block. So we in California, when we think about how do you implement these blueprint principles in a carve-out state, we brought a group of people together to say, what could our vision look like? How could California be different in 5 years to really serve the people we want to serve? Next slide. So we actually came up with our own blueprint. We're calling the Medi-Cal blueprint to distinguish it from the national blueprint. And this was a really interesting process of convening and bringing people from different organizations and asking them, don't bring in your organizational hat that is going to be fighting for the right of counties or fighting for the right of plans or looking only to advocate from your narrow point of view. Think about California as a whole, come in as an individual, bring your best thinking and help us create a vision. And we were really excited, next slide, because the vision that came out was really, really bold and surprisingly bold because everyone stands to win in a better integrated system, but in the short term, everyone may lose a little bit of their particular niche that works well for them in the status quo, but does not ultimately serve the people we want to serve. And so the vision is that by 2025, all Medi-Cal enrollees experience integrated high-quality care managed by a single entity accountable for payment, administration, and oversight. And this is not going to happen overnight. We're not naive. We actually visited a small state that we heard where the Medicaid director looked at it and said, this doesn't make sense. Carve-out doesn't make sense. We're just going to roll it in next year. It's possible in states like Tennessee. It's really, really difficult and complex in a state like California. So to get there, we're going to be looking at regional models. How do you have willing counties and willing plans come together and figure out how to solve some of this complexity in a way that works for our consumers, and to test out things that work in some regions that may not work in others. So that's where we're putting all of our effort, is to bring the principles of the blueprint to our state through changing policy and payment, and we'll keep you posted on our progress. Next slide. I think this is where we switch to Q&A, and thank you for your time.
Well, thank you all for that tremendous presentation, and thank you for going through a lot of wonderful information in a very timely manner. So we do have time for questions and answers at this point. Remember that you can type those in at any point, and I will be happy to read them to our presenters until we run out of time. But one of the first ones is, I'll direct this to Susan. The question is basically around, can these principles be used for children? And maybe you would like to explain a little bit about the origin of this work, as originally and initially focused on older people, and any plans for having this go to children as well.
Thanks, John. I think that the principles of care that is centered around people's priorities, goals, and needs, and that in a coordinated way, works with people to develop plans of care and a way that they can get the range of services and support that they need in order to thrive, really goes across all age groups. I think, John, you really allude to a very important, highlight that many people in geriatrics and working with older people have really understood this for many years and taken this approach for many years. Some are really able to integrate it across all of their work. Some face challenges, like, Kelly and Mark really pointed out the challenges of paying for this kind of care, this kind of really coordinated person-centered care. But I think it really goes across populations, and we have a lot to learn from work with kids and from work with older adults. I think that there is, of course, there are different knowledge base that you need to work with kids and to work with older adults. And at this point, we are really focusing, just because we needed to, really, focus so that we could make some progress on adults and older adults. But we in the foundation are also doing a lot of work with kids, and a lot of work with kids facing great challenges, and we are looking at how to integrate that work into this world as well. Thank you.
Thanks so much. Mark, I'll aim this next one at you, but anyone could answer. We have actually several questions which are basically around asking about specific areas of focus within this general framework. One being oral health, and another being mental illness, behavioral health issues, particularly serious ones, and of course the challenge that creates in providing complex care services. So could you talk a little bit about how you see this framework helping to move either of those areas forward, or what that process will be?
Sure, John, thanks. So, I think one of the ways that we describe the field of complex care is as a bridging field. So what we mean by that is that it's really seeking to connect different existing specialty areas and fields of practice to work better together, and to draw on some of the modalities that folks say in behavioral health maybe have developed, but that need to be more broadly applied. So whether it's oral health or psychiatry or a range of different sort of existing specialty areas, the ecosystem really is seeking to find more effective ways to coordinate those services, to get people working in highly effective teams, and so they're going to have to be part of that, because the prevalence of serious mental illness and other behavioral health disorders within the population is extremely high, and similarly issues of oral health are significant for the population. So it's really trying to create some of those frameworks and structures by which collaboration can happen across previously siloed and sort of disjointed, fragmented care delivery structures.
Thanks so much. I will direct this next one, although once again anybody can jump in, to Kelly. So you are a representative of one of the major healthcare foundations in the United States. And to what degree is participation in this program limited to larger state and national foundations? And I guess the flip side of that question would be, do you have examples of ways in which smaller local foundations can participate?
Great. I think by program, if you mean implementing the blueprint, I think the blueprint applies to small and large. It's a set of principles that you would use to figure out what it takes to make change in your area. If you're thinking about the program of kind of the way we're trying to approach it, a lot of how we move forward is partnership and thinking and reaching out to our local partners and figuring out what problems they're trying to solve, and how our strategic effort to improve outcomes for people with complex needs is lined up with the problems they're trying to solve. So I don't know if I'm answering the question. If the program is related to the Transitions Clinic Network, that's a particular care model that is, we're absolutely looking for partners across the U.S. And so you can go to that website and communicate with them directly or communicate with me, because they're actively recruiting new sites to implement the model. And again, that model is very much aligned with the blueprint.
Okay. Susan, anything to add to that one?
I think it's kind of the more the merrier. I think that there are so many different so many different settings and so many different partners and perspectives needed in this work that I really agree with Kelly that we need as many partners as possible.
John, if I could just jump in, I think we at the National Center think that while the national blueprint is helpful to sort of coordinate efforts across the country and bring them within a framework, that the actual implementation of complex care happens at the local level. And so when we talk about that ecosystem, that's really happening in local communities across the country. And the National Center, one of the things we're doing this year is hosting a series of regional convenings because we recognize that people don't always have the ability to go to a national conference, and that we need to come directly to local communities to participate. So, I think there's lots of things that a local foundation could do to allow to give resources to organizations to be able to convene the right stakeholders, to maybe get some expert consulting, or to just have time to work through problems around data sharing or joint planning, or other things that will help to strengthen local partnerships and develop a complex care ecosystem. So a lot of this work has to happen at the local level.
John, can I just add one more thing to what Mark said, because I thought that was such an important point?
Sure.
Yeah, I think absolutely, right. We talk nationally or we talk statewide, but, in actuality, people don't live nationally or statewide. They live where they live, and people work and get the care exactly where they live. And many of the innovations actually come from, smaller programs. And I think that the idea that we can really share resources, that no matter how small or large an organization is, or no matter how small or large a funder is for that matter, if we tap into what people are already doing across the nation, and we can support efforts at all levels, both at the implementation level and at the funder level, I think that that's really going to move us forward.
Well, thanks. This is an interesting one. We in the health philanthropy world work a lot today on social determinants of health. How do you see this process fitting into that, and in what way is it specifically useful for people who have that as their prime goal? I'll let anybody take that one.
Yeah, I'll start, and would love to hear what Susan and Kelly have to say as well. I think social determinants, social factors, social sectors are a key part of complex care. Those issues are not limited to the most complex, but I think, as Susan said, it's a great opportunity, a test case for really being able to incorporate that into the standard of care in a way that can create a return on investment, can sort of help to lay the groundwork for a broader conception of health that addresses not just sort of traditional healthcare medical issues, but gets into the social issues. So I think they're intimately intertwined. The addressing of social determinants is a core sort of foundational piece of any complex care program. It's just, the focus may be on a broader population versus a narrower population. That's where sometimes it may differ, but I think there's a lot to be learned in both directions, and there's a lot of good collaboration going on with organizations like Health Leads and others who are focused on addressing social determinants of health for broader populations. So they're not inconsistent with each other. In fact, they have a lot to learn from each other.
This is Kelly from HCF. We've thought about this a lot because we used to have some big funders in the California healthcare space, and credit to them, they realized that they wanted to move upstream to try and tackle some of these social determinants directly as opposed to through healthcare. And we've made the decision to stay in healthcare, but we have to have a healthcare system that can respond to people, take care of people, improve outcomes for people whose primary drivers are insecure housing, food insecurity, violence, all of the things that people show up with when they show up into a community health center. So we're staying in the healthcare system, but we want to have a healthcare system that is informed by trauma-informed care, that is able to help people who have these unmet social needs get those needs met through the healthcare system.
Susan?
Yeah, and this is Susan. I think to add on to that, those are really critical points. And I think that none of us want to just keep treating symptoms. Of course, there are people now alive, who have really a range of complexity of needs. And of course, we are all working together to really address those. But the point is we are really, I think many of us also focused on addressing the root causes of why does somebody end up with a complex set of health and social challenges. It's things like homelessness, it's things like racism, it's things like income insecurity. So I think that and that's why I think programs and funders really need to work together, because we need to address both of these root causes of these social determinants of health, as well as provide as good and integrated care system as we can for people who already are facing these challenges.
Well, thank you. That's a great way to bring us to the end of our questions. We have a few more, and we will send those to our presenters after this presentation. But I do want to turn now to each of them and ask them for their final words of wisdom to our audience. And Susan, we'll start with you.
Okay, I don't know if this is a word of wisdom, but I'm offering up some words. So I think that, many of you listening in on the phone, and certainly my two fellow presenters, have done so much work in this area. And I think we've really made great progress from where we started, also in terms of not just seeing that as this is a Band-Aid solution, as we've been discussing, but addressing root causes, really working, across systems, across professions, and really all working towards this idea of, both addressing the root causes and building care and systems that meet people's and communities' needs in a way that makes sense to them and that really fits in with their priorities. I think what I keep trying to remind myself, and what I think we really all have to faithfully do when we are in this field, is to remember to keep people and their needs and their wisdoms front of center in this work, and to design and implement with and not for people, and to really see these patients and community as our partners, and really helping us to figure out the best way to work with them and to address some of these really thorny challenges.
Susan, Mark?
Great. I love what Susan just said, and I would sort of draw a parallel to the field itself and how it's going to develop. I think we are incredibly fortunate to have a group of individuals and organizations who are incredibly committed to this kind of work, to serving the most vulnerable, to trying things differently, and to really trying to remake how we produce health in this country. And so we have been just so pleased by the reception that the Blueprint has gotten from folks, and it just reminds us of the strength of the community of this field of complex care. And so it's our job to really make sure that we create as many opportunities for folks to connect with one another, to share the learning that they're having, because there is so much knowledge and wisdom that sits in the field that needs to be shared and developed into tools that make it easier for everyone to do this really difficult work. So we'll be calling on all of you for help over the next couple of years as we try to live out this blueprint and turn it into actionable resources and tools and shared learning for everyone. But it's really, this is a field that's going to be built by the field itself. Thanks.
And Kelly, we'll come to you.
Thank you. You know, I was reflecting on a New Yorker article by Atul Gawande that I just reread yesterday, and it talks about how slow change happens, like why ideas take a long time to implement in healthcare. And he goes back to the 1840s when they invented ether. You know, as soon as they had ether, it was in every operating room around the world within a year. But when they figured out that you should wash your hands before surgery, that took 100 years to pull off so that you could expect consistently to walk in an operating room and have it be clean. And unfortunately, this is one of those things that is going to be slow change, because in order to get clean operating rooms, you had to have government and regulations. You had to have hospitals get paid better if they did well and paid less when they did poorly. You had to have consumer activation and data transparency and workflows, and it's something that seems relatively simple. When all of those things pull together, even though it's complex, it happens. And I'm really grateful for the blueprint, because I think it provides the kind of clarity of language and clarity of action and clarity of our, you know, who are we trying to serve, and making sure that they're at the table with us. And then we can start doing the hard work of changing policy and payment, data, clinical models, working with new partners. So I'm excited to be part of the process, and thank you for your leadership.
Well, thank you so much. We want to particularly thank today our great speakers, Mark Humowicki, Susan Mende, and Kelly Pfeiffer. We thank you for all that you do to make life better for older adults and people of all ages. I also want to thank the Six Foundation Collaborative that consists of the Commonwealth Fund, the John A. Hartford Foundation, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, the SCAN Foundation, and Milbank Memorial Fund for their support of this work. We also thank our friends at Grantmakers in Health who participated in today's webinar. We will be making this presentation available to anyone, including both the slides and the audio. Just watch for the rebroadcast link on our website. And finally, I want to thank all of you for participating in today's webinar. Have a great day.